Hello, in today's online lecture, still covering cardiovascular disorders, we're going to be looking at heart failure. Before we get into the topic of heart failure, it's important to give you a little bit of relevant normal anatomy and physiology background, starting with vasomotor pressor reflexes. These are autonomic reflexes, meaning they occur automatically throughout the body without our control. And they involve what are called baroreceptors. When you think back to homeostasis, you have to remember that under normal circumstances, right now, for each and every one of you, our body is constantly, non-stop trying to maintain homeostasis as we deviate away from it. And this is done by various different mechanisms, but in terms of what's relevant today, it's by controlling our blood pressure, because our blood pressure will go up and down, but we need to keep it at its homeostatic level in order to just really survive. And so our body has these built-in presoreflexes called baroreceptors. And you might remember that baroreceptors, which you can make note of, are really stretch or pressor receptors, meaning that they're receptors that are going to be picking up changes in pressure or stretching of a vessel, are located within the aorta and the carotid arteries. So if we look at the heart here, remembering that this is the aorta, we have these presoreceptors that exist here, but then remember the carotid arteries that will branch off a component of the aorta and travel up on either side of your neck. They also contain baroreceptors. And so these baroreceptors are made up of these sensory nerves. And these sensory nerves are what are going to be picking up changes in the stretch of the vessel itself. Now, what will impact the stretch of a vessel? Well, if you think about it, when you have an increase in volume, so there's more blood, it's going to cause more of a stretch against the walls. And when it creates a stretch against the walls, that tells us that there is an increase in pressure. And so this information is going to be fed back to our central nervous system so that we can make adjustments to constantly maintain normal blood pressure. So let's look at two different circumstances. Let's look at the situation that I started to describe, is that there's an increase in blood pressure. So when there's an increase in blood pressure, it's going to be detected by these baroreceptors found in the aorta and the carotid sinus, and this information picked up by sensory receptors will be fed back along a sensory pathway to two main areas. We have these cardiac control centers, so this is going to control our heart, and these vasomotor centers that are also found within the central nervous system, specifically within the brainstem, the medulla oblongata more specifically. And so when it receives this information, it's going to interpret it. And it's going to look at it and say, okay, well, the set point for blood pressure is this. This is what we want it to be, but it's now higher at this. So we need to, that is the medulla oblongata, we need to send out a response to the heart and to blood vessels in order to make a change to bring us back to our set point or homeostasis. And so this is going to involve our parasympathetic and our sympathetic nervous system, remembering that these two here are part of the autonomic nervous system. So what sort of effects are we going to see when there's an increase in blood pressure? Well, we're going to see an increase in parasympathetic output, remembering that parasympathetic is our rest and digest. So this will help bring blood pressure back down. And we're also going to see a reduction in our sympathetic output. The sympathetic nervous system is our fight or flight. So if we bring this down, it's also going to have a positive impact on our blood pressure. Now, more specifically, what is it that's happening? Well, one of the things we're going to see, if we look back here, is that the output, this motor output, is going to travel to the heart, and it's going to signal the heart to slow its heart rate. Now, why is that important? I need you to kind of think about what I'm about to say to try to understand it. If we increase our heart rate for whatever reason, what's the result going to be if we increase our heart rate? Well, what it means is that, let's go to this left ventricle. If we increase the heart rate, it means that we're going to be putting out into our systemic circulation more blood, more volume of blood. Why? Well, if the heart is beating faster, it just means more is being output into the systemic circulation. Now, how does that impact blood pressure? Well, I want you to make an association, this is very important, between blood volume and blood pressure. I want you to think of a balloon. If you have an empty balloon and you start filling it with water and you continue to fill it until it gets larger and larger and larger, so you're increasing the volume within it, what is that going to do to the pressure within the balloon? Well, it should make sense that it's going to increase it because we keep filling it and filling it and filling it, it's going to increase the pressure. So make an association then between volume of a fluid, let's say, and pressure. So when we increase volume, we increase pressure. So in other words, if the heart is beating faster, it's going to put out more volume of blood into the systemic circulation. That is in itself going to increase blood pressure because of the association I just described. So if we can send a signal to the right atrium, you may recall, or the right atria, you might recall that this is where the SA node is located, which sets the pace of the heart. It's going to tell it to slow down. And if it slows down, that is the electrical current that's sent throughout the heart, which would then follow with a contraction, then it means we're putting out less blood into the circulation. Less volume of blood means less pressure, and this is what helps bring down our blood pressure. Now that's a change in heart rate, and that's by that cardiac control center shown here. But we're also going to have an impact on blood vessels, that's the vasomotor center. But what happens exactly? Well, we're going to see blood vessels dilate. That means they're widening. We're increasing the lumen size of the vessels. Now, how does that reduce blood pressure? Well, if you widen something, the blood that's flowing through it has less resistance. If you constrict it, now all of a sudden, the blood that's moving through it has more resistance just against the walls of the blood vessel. It's harder to get through it. So you can think of a straw. Let's say you have two straws. One of them is a thick straw and the other one is a very thin straw. It probably makes sense to you that if you were going to drink some water from a bigger straw, you're going to get more water into your mouth. But if you drink through a smaller one, you're going to get less water in your mouth if you compare it at the same rate. And the reason for that is because the thinner straw is going to create more resistance of the water against the walls of the straw. When you widen it, there's less resistance, so it can move faster. You can also think of if you have a narrow river versus a wider river, the speed at which the same volume of water can move through it is going to be different. And so we can apply the principles that I just discussed to understanding how vessel diameter can affect the amount of blood flowing through it. So dilating the vessels, meaning widening them. So let's say it was like this. Blood is going to have some resistance as it's moving through it, but if we widen it, there's less resistance moving through it, less pressure exerted now against the walls, which will reduce blood pressure. So I'd like you to make note for help in later lectures and later topics is that vasodilation you can associate with a reduction in blood pressure. Vasoconstriction I want you to associate with an increase in blood pressure. Now let's look at the opposite scenario. Really less important than this one as far as the cardiovascular disorders. Let's say there's a reduction in blood pressure, meaning that the blood moving through here is not applying a whole heck of a lot of pressure against these vessels. And so the baroreceptors are going to pick up the information, send it back to the cardiac and vasomotor control centers, and then the medulla here is going to look at the situation and say, okay, we're supposed to be this blood pressure, the set point, but it's quite a bit lower than that. And that's a concern because we need enough pressure within our systemic circulation in order to drive blood or the nutrients and oxygen within it into our tissues. If the pressure's not high enough, then our tissues can be deprived. And so it wants to bring us back to our set point. And in order to do so, we need to bring the blood pressure back up. And so what will we see? Well, we're going to have now the opposite, a reduction in parasympathetic output. So we're not going to create rest and digest. We're not going to slow this down. We're going to pick up the heart rate. Picking up the heart rate means, as we've already discussed, that that left ventricle is going to be pumping up more volume of fluid at a faster rate into the systemic circulation. And an increase in volume means an increase in pressure. But there's another variable that occurs. We're going to now see an increase in sympathetic output. So remember the sympathetic chain as part of your normal nervous system anatomy. The sympathetic chain here is going to send out a signal to the heart to make it contract faster. It's also going to send out signals to your blood vessels, causing them to constrict. Going back to the principles that I've already discussed, if you have a vessel that's this wide and then you constrict it, blood has a harder time moving through it and it creates resistance against the walls. And that resistance against the walls, that pressure against the walls, your blood pressure is going to increase. Now remember, this is all happening on a normal basis all the time as our body tries to maintain homeostasis. But when we talk about diseases and conditions such as heart failure in today's lecture, maintaining homeostasis becomes a lot more difficult, as we'll see today. I'd like to give you one more example before I talk to this slide about vasodilation and vasoconstriction in order for you to have a better understanding about the resistance that blood will have against the blood vessel walls and the differences during vasodilation versus vasoconstriction. So I want you to picture this. I want you to picture a whole bunch of people in a room. And all these people in a room need to move through a hallway. And there's this wide hallway for all of them to move through, and they all have to move through together, thinking that the people are like blood and the hallway is going to be like our blood vessels. So all these people, we say, okay, go. These people have to all move at a decent pace through this wide hallway, but no problem because the hallway is wide. But then all of a sudden, as they keep going, the hallway starts to narrow or constrict if we're talking about our vessels. Now with this constricted, now everybody's kind of tight against each other and the people on the outside are feeling friction against the walls as they're trying to all push through this narrow hallway. And then the hallway opens up wider and now everybody can sort of space out a little bit and move faster through. And then the hallway narrows again. Everybody has to come closer together and there's more resistance. It's more difficult to move through all of those people at the same speed when you've narrowed the hallway compared to widened it. And so that is true as well when it comes to the movement of blood through our vessels. When they vasoconstrict, it's more difficult to move the blood through it, which increases blood pressure. Just like when people are moving through a narrow hallway, it increases pressure against the walls of that hallway. And then when we widen our vessels, the blood can move through it easier with less resistance in its periphery. Compared to people moving through a wider hallway, there's less resistance that the people are going to feel or have against the walls of the hallway because it's wider. Okay, Little bit more on normal anatomy, still talking about those baroreceptors and the reflexes that occur. So the reflex, just going back to that slide, is it picks up information and then reflexively sends that information back and then reflexively sends out an output, whatever it may be. When you are lying down on your back, so we'll say a supine position, so this is supine here, blood is sort of evenly distributed when you're lying down because you don't have gravity pulling towards just your feet like when you're standing. But when you stand up, so you move from supine to a standing position, now because of gravity, blood is going to pool within the peripheral veins, so really within your legs, so gravity pulls on it. This is seemingly a problem because if we have more blood sitting in our peripheral veins, gravity pulling it down, it means less blood is returning to the heart because we know veins will return blood to the heart. And that's a concern because if we are returning less blood to the heart, it means that we're going to be pumping out less blood. That's our cardiac output. And so if we pump out less blood, then less blood leaving the heart means less volume of blood leaving the heart. And what that's going to do is create a reduction in blood pressure, remembering that if there's less volume being pumped out, there's going to be less pressure as well. But we lie down and stand up all the time. So our body has this natural compensatory mechanism to correct for that. And so when we do notice initially that there is that reduction in blood pressure by those baroreceptors, those sensory afferent receptors, we know it's going to send that information back to our central nervous system, as we spoke about before. And a reflex is going to be activated. It's automatic. It's going to send out a response that's going to be sympathetic. So what I'm describing here is this part here, that reduction in blood pressure. It's going to send out a sympathetic response, which is going to involve an increase in heart rate, as I already described, as well as vasoconstriction. That vasoconstriction, what that's going to do, think about this. If we constrict the vessels here, it's actually going to push blood upward, returning more blood to the heart. So this increases the amount of blood we pump out, our cardiac output, and our blood pressure, bringing it back to normal. This is why sometimes, and you may have experienced this yourself, if you're lying down on your back and then you get up really, really quickly, and you feel a little bit lightheaded, the reason for that is because you haven't really given your normal homeostatic mechanisms a chance to kick in because you moved so quickly. This looks like a pretty busy slide, but there's only a few things I want to point out to you. And the first one is that at any given time, so if we're looking at this chart here, at the total volume of blood within our body, our systemic veins and venules, venules being small veins, have the most amount of blood sitting within it. So this is sort of like a reserve. So this goes back to what I spoke before, that let's say we needed more blood pumped out by the heart. If we constrict our systemic veins and venules, that's going to push more blood back to the heart. More blood means more pressure. The next thing to point out, and this should be pretty obvious, is that the pressure measured in millimeters mercury is going to be highest within our large arteries, larger arteries than the smaller ones. And that should make sense because what our our heart is trying to do is pump blood through the aorta and the arteries in order to get it to the rest of the body so that the tissues can use it. And then pressure is going to drop when we get into capillaries and venules and veins. And so in order to pump blood out of the heart, it should make sense to you that that left ventricle is going to be under the highest pressure because it has to push blood out of the heart and into the systemic circulation. These diagrams here are just reminding you of the normal flow of blood throughout the pulmonary and systemic circulation. But this top diagram is showing you a bit more detail as far as the tissues within our body that receive the most amount of blood. So when the left heart pumps out about 5,000 milliliters per minute, or we could say 5 liters per minute of blood, you can see it is distributed to many different organ systems. However, it's not equal, and that's because certain systems need more blood than others. And so you can see that skeletal muscles, our gastrointestinal system, and our kidneys require quite a lot of blood delivered to it for their normal function. So you don't need to be aware of these specific numbers. All right, now we're getting to today's topic, which is heart failure. So how do we define heart failure? Well, it's a pathophysiologic condition. That's of course why we're learning it in this course, but it occurs when the heart is unable to generate an adequate cardiac output, which will lead to inadequate perfusion of tissues. What's perfusion of tissues? Well, it's really the blood supply that's able to reach the tissues and perfuse it, supply that tissue with the oxygen and the nutrients that it needs for survival. Now, what is cardiac output? I've talked about this term already, and you would have learned about this in the past, but to remind you, it is stroke volume times heart rate. So stroke volume is the volume of blood that the heart pumps out with each stroke or contraction. So in other words, think of this left ventricle as contracting. The volume that it pumps out with one contraction is your stroke volume. And we multiply that by heart rate. So we're multiplying it by a factor of time. And what that will do, so heart rate is the amount of times that your heart beats per minute, is provide us with our cardiac output, meaning how much is our heart pumping out per minute. Now I'm going to describe two terms, end diastolic volume and end systolic volume. Let's break up these words to understand what they mean, which can help you understand the concept. Volume is referring to the volume of blood in the ventricle. Diastolic refers to the filling phase. Systolic refers to the contraction phase. So the diastolic volume is referring to the volume in the ventricles when it's filling. And so end diastolic volume is at the end of the filling phase, how much blood is in the ventricle. This here is showing you or representing, let's say, the left ventricle, and this is the end of the filling phase, so the ventricle is full. That's your end diastolic volume. End systolic volume has to do with the volume of blood in the ventricles at the end of the contraction phase. So we filled the heart. Now when the heart contracts, we know we pump out our stroke volume, which we can express as a fraction, the ejection fraction, as you'll see next. But what's left in the heart after the contraction, what's left in the ventricle, is the end systolic volume, the volume of blood in the ventricle at the end of its contraction. Now you might wonder why there would be anything left. Well, we don't pump out all of the blood within the heart, as I'll describe when I talk about ejection fraction next. What is ejection fraction? So this is the proportion of blood, so it's expressed as a fraction or as a percentage, that is pumped out with each contraction. So what this means is that if this is 100% of the blood in here, we don't pump all of it out. And that might surprise you that even with the most healthy hearts, we're not pumping all of it out. The percentage that we pump out, so the stroke volume when we express it as a volume, the percentage that we pump out is our ejection fraction. So I can restate that and just say ejection fraction is the proportion of this diastolic volume that is ejected during a ventricular contraction. And what I want you to make note of is that the normal range is anywhere between 55% and 75% in healthy individuals or typical healthy individuals. And it will range depending on the age and the health of that person. So if normal is between 55 and 75%, what that is saying is that of the 100% here, we will normally eject anywhere from, depending on the person, 55 to 75% of that end diastolic volume. Now, ejection fraction, that percentage is going to decrease or decline when the myocardium of the heart is failing to function properly and it can't pump out enough blood to meet the body's needs. And so an example would be a heart attack. If somebody has a myocardial infarction and the left ventricle, let's say, is affected and it can't pump out the normal amount of blood, then if there's a reduction in stroke volume, then there's also going to be a reduction in our ejection fraction, the percentage that we pump out. And what I need you to be aware of is that an ejection fraction of less than 40% means that the heart is failing. It is unable to generate, the heart is unable to generate an adequate cardiac output in order to properly perfuse vital tissues. So this is a number you do need to be aware of. The final concept on this slide involves terms preload and afterload. I can't tell you how important these are for you to understand before proceeding on through the rest of this lecture, and in fact it will help you with later lectures as well. So this should really just be a basic understanding that you have, just like the flow of blood throughout the pulmonary and systemic circulation. So starting with preload, I want you to think of the word preload as the blood that loads the heart. It's preloading the heart with blood before we pump it out. But more technically, preload is the volume of blood that's in the ventricles at the end of the filling phase. So really that's like your end diastolic volume that we already spoke about. But the volume ends up creating this pressure because we know there's an association with volume and pressure. More volume is more pressure when we talk about the volume of blood. So preload then would be the amount of blood that fills the right ventricle, that fills the left ventricle. Remembering that blood is going to fill the atria on the right and left side, and then it's going to end up in the ventricles. And so the volume of blood that ends up in here is the preload. So think of it if you have, say, a water gun, and before you shoot a water gun, you need to fill the water gun with water. You're preloading it before you're going to eject the water from the water gun. Just like we need to preload the heart with blood before we can eject anything out of it. Afterload. Afterload is the resistance that either ventricle really must overcome in order to circulate blood. Well, what does that mean? Let me get my laser. So we preloaded the heart. Let's look at the left ventricle. What happens next? Well, we know that this left ventricle is going to contract to push blood into the aorta, so into the system and out into the systemic circulation. But afterload has to do with how much resistance that left ventricle has in order to push blood through. How hard does this left ventricle have to work to push blood into the aorta and into the rest of the circulation? Similarly, with the right ventricle, it's been preloaded, but afterload is how hard it has to work to push blood into the pulmonary arteries. And so there are certain states and conditions that can increase afterload. And if we increase afterload, it means that the ventricle has to work harder to push blood through it. One of the examples that we're going to be talking about today is atherosclerosis. And so I want you to think about the systemic arteries, many of them filled with atherosclerotic plaques that harden the vessels. The hardened vessels, the narrowed lumens, mean that this left ventricle, to achieve the same thing in a normal healthy body, is going to have to work that much harder to pump blood into the aorta and then through all those narrowed vessels. So atherosclerosis is an example of an increase in afterload, meaning making that left ventricle work harder. So you don't need to make note of this yet because this will come up later. I'm just wanting to bring it up while I'm talking about this concept. Just to give you an example to help you understand increased afterload on the right side of the heart. There are many different examples, but one example would be, well, we know that this right ventricle is going to pump blood to the pulmonary circulation. Let's say in this person's lung, there's some sort of tumor, for example. The right side of the heart might have to work much harder to push blood past that tumor to where it needs to go, increasing the afterload, the resistance that the ventricle must overcome in order to push blood out and have it circulate properly. So the first 2 points I've already spoken to you about in terms of defining heart failure. So that ventricle is unable to properly, when it fails, properly pump enough blood into the circulation in order to properly perfuse your tissues, and so they will suffer. So the goal here, this is actually one of my favorite diagrams, the goal here is that this left ventricle needs to be able to work properly to pump blood into the systemic circulation and perfuse all our tissues. Just like the right ventricle has to be able to push blood into the pulmonary circulation in order to oxygenate it so that it can then return to the heart. It affects nearly 10% of individuals that are 65 or older, so it is something that is quite a consideration clinically for our aging population. I would not test you on those numbers. But you can see that, or probably understand that it does increase with age. It is the most common reason for hospital admissions within this age group is a failing heart, either left or right-sided. So we can have then 2 different types of heart failure. A lot of times we just think of our heart as the heart, but remember it has a right and left side which do very different things. So each side, or one side versus the other, can fail. And so the rest of today's lecture is going to be taking the principles that we've just discussed earlier in this lecture and applying them to the right heart failing and the left heart failing. This slide is really just a summary of what we're going to get into more detail on. So the right heart failure is also known as cor pulmonale, and that will make more sense later. The left side of the heart failing is also known as congestive heart failure. Right heart failure is less common than left heart failure. The most common cause of right heart failure is lung disease, and I'm going to be explaining using a diagram why that is. Whereas the most common cause of left heart failure is ischemic heart disease, meaning that the heart muscle itself had a reduction in blood flow to it that caused the tissue to not have enough blood supply to function properly. Right heart failure, as you'll learn today, can lead to peripheral edema, whereas left heart failure can actually lead to right heart failure. So all of this should make so much more sense by the end of today's lecture. But what I wanted to point out to you, because I do consistently ask this on tests, is the cause of each. So please be aware that the most common cause of right heart failure is lung disease, and the most common cause of left heart failure is ischemic heart disease. Now I'm going to start talking first about right heart failure. So the next number of slides are specific to right heart failure, including this slide. So you can make note of that. Remember that I told you on the last slide that the most common cause of right heart failure is some sort of lung disease. An example of lung disease that can lead to right heart failure is pulmonary hypertension. Okay, so make note that pulmonary hypertension, which is really just high blood pressure within the pulmonary arteries. So remember, these are the pulmonary arteries here, and then smaller arteries within the lungs. High blood pressure within these vessels is known as pulmonary hypertension. And so pulmonary hypertension then, again, is really a form of lung disease or related to lung disease that can cause right heart failure. More specifically, though, pulmonary hypertension is defined as an increase in pressure, average pressure within the pulmonary arteries, 5 to 10 millimeters mercury above normal or above 20 millimeters mercury within the pulmonary arteries. You do not need to know those numbers specifically. A lot of times when we talk in this course about different causes, we will look at primary forms and secondary forms. Primary forms of pulmonary hypertension, called primary pulmonary hypertension, are a lot of times idiopathic, where there's no specific cause. It's not known why there is an increase, but what we do know is that there is some imbalance a lot of times between the production of vasoconstrictors and vasodilators. And when this is thrown off, if we vasoconstrict the pulmonary arteries, hopefully you can appreciate, based on our conversations earlier, that this would increase pressure, more resistance against the walls when we constrict them. We want a good balance between vasoconstrictors and vasodilators. When somebody is experiencing primary pulmonary hypertension and it's not fixed, what will occur is the production of these growth factors that lead to remodeling. In other words, as the blood is moving through the pulmonary arteries, over time, the walls of the arteries basically say, I can't handle this anymore, and I'm going to have to adapt and adjust. And so there's this production of vascular growth factors that cause the arteries to remodel. And that's not a good thing, because we're designed a particular way so that in the case of our pulmonary arteries, they'll do what they need to do. But if we remodel them, then that's going to change their function, because we've changed the structure. Secondary pulmonary hypertension oftentimes is caused by the presence of scar tissue, or somebody has COPD. So we'll learn later in this course that emphysema is a component of COPD. Anytime we have diseased lung tissue, that diseased lung tissue is going to have a more difficult time oxygenating the blood. So if we have scar tissue, let's say here, if this right ventricle pumps blood into the pulmonary artery, and then it gets to smaller arteries, and eventually the blood will reach the alveoli, which oxygenate it. But if there's scar tissue here, it's going to have a more difficult time reaching it. And so what the body does to compensate for this is it causes the pulmonary arteries through here to vasoconstrict. They vasoconstrict in order to divert blood to, in theory, healthier tissues. So if the blood's heading this way and it's not able to be oxygenated, vasoconstriction will sort of push it to another area that in theory would be able to oxygenate it. That's called pulmonary artery vasoconstriction. But there's a bit of a problem that will occur with that. If we get constriction of these vessels here, these pulmonary arteries and the branches, that normally shouldn't happen. All of a sudden, what we've done is we've narrowed the vessels through here. If we narrow the vessels through here in one area, it means less blood can move through it. So it's going to back up and increase pressure back through here. So think about what we've done. We've had what used to be like this. So let's say for simplicity, here's a lung, and we have the normal flow of blood through here. If all of a sudden we kind of narrow and vasoconstrict, then the blood that was moving through here can't move through it at as fast of a rate. And so it starts to kind of back up a little bit. And the problem is we're still putting more blood into it, but we're not able to get it through at the same rate. So it kind of backs up. And when it backs up, that means there's an increase in the amount of volume that's present here. Increase in volume means increase in pressure. And so what we're going to see today in upcoming slides is that if we get narrowing of the pulmonary arteries here, so that's called vasoconstriction, and I told you that that's done to sort of divert blood to healthier lung tissue. If we narrow this area here, it's going to cause less blood to be able to move through here. Less blood moving through here in this direction means it's going to build up here because we're still throwing blood into it. That increases pressure. An increase in pressure here is pulmonary hypertension, high blood pressure within the pulmonary artery. And as we'll see soon, this right ventricle now is going to have to work that much harder just to push blood through that resistance. And that, you may recall, means that now we have an increase in afterload, the resistance that that right ventricle has to overcome to push blood to its destination. So although this will come up again, especially in our respiratory disorders lecture, if somebody has maybe scar tissue that has formed or they have another lung disease here, what's going to end up occurring is that we can't oxygenate the blood as well. And so the body will undergo that pulmonary artery vasoconstriction in order to really detour the blood to healthier tissue. But when it does that, that constriction causes blood to back up into the pulmonary artery, which causes there to be an increase in volume and an increase in pressure against the walls of the pulmonary artery. That will increase the resistance that that right ventricle now has to overcome just to push blood to where it needs to go. So really, the obstruction within the lung, let's say scar tissue here, and the increased pressure through here are all making this poor right ventricle have to work so much harder to achieve the same thing. Before I move on, I just wanted to give you a bit of an example further describing this because it will come up again and again. This pulmonary artery vasoconstriction that occurs. Think of yourself driving on a highway to get to your destination, and then you look ahead and you realize that there's a complete roadblock, maybe something collapsed onto the road and you can't get to where you need to go. What's going to happen? Well, you're going to be detoured in another direction to get to where you need to go. And that's sort of like what happens within the lungs, is we're trying to move the blood to another area of lung tissue that might be able to better oxygenate it. So it's our body's trying to survive, but even those survival mechanisms end up causing problems. Now, if the pressure here is sustained long enough, like anything, it can start to remodel to adapt to it. But if we can correct the primary condition, what is the main problem? In this case, the scar tissue or the emphysema, if we can correct the problem or at least reduce the severity of it, then the pulmonary hypertension that resulted can also be corrected. Okay, so understanding what I just spoke about is important before we move on to the next slide, because I'm going to be drawing in those concepts into talking about specifically the right heart failing. So let's say somebody has lung disease. Maybe it's COPD or the emphysema I described earlier. Maybe they just have pulmonary hypertension on its own, or maybe they have both. In any case, as I've already described to you, there's going to be an increase in vascular resistance within the pulmonary circulation, meaning that because of the, let's say, lung disease here, because of the high blood pressure within here, there's an increase in resistance to push blood through here because there's a roadblock. There's a narrowing of the vessel. This is an increase in afterload. The resistance that right ventricle must overcome in order to push blood to where it needs to go, in this case, the pulmonary circulation. So if there's this increase in afterload, the right ventricle is going to say, like, what the heck's going on here? How am I going to get blood where it needs to go? Well, I'm going to contract harder. So the right ventricle is now going to contract harder than is considered normal. The problem with that is because it's working harder, its oxygen demand is going to go up, but it's not necessarily going to be getting more oxygen. And so it starts to experience hypoxia. The cells work harder, they use up more oxygen, now they're deprived of the normal amount of oxygen that they need for survival. And so in this hypoxic state, the ventricle gives up. Now it can't contract very hard at all. And when it can't contract very hard at all, it means it's not able to pump out the normal amount of blood into the pulmonary circulation, so less blood leaves the right ventricle. If less blood leaves, more blood accumulates. And so if we leave more blood in here, instead of getting the right amount out, and we're still filling the right ventricle, normally, this is going to increase that end diastolic volume, or increase the preload. But this preload is increased, it's not normal. We have too much blood in this right ventricle. It keeps filling, it starts to stretch, and now we're increasing the pressure within the right ventricle. Because remember, increase in volume of blood is going to cause an increase in pressure. Well, what's going to happen now? Well, if it can't get out properly because that right ventricle is weak, it's going to start backing up. And so now we're increasing the preload, or the amount of volume of blood within the right atria. Increased volume is going to increase pressure. So now we see an increase in pressure within the right atria. So what happens from here? Well, the right heart's failing, obviously. It's failing to pump blood into the pulmonary circulation. And so what's happening is it's backing up. And this backing up is important in terms of understanding the backing up for the clinical signs and symptoms, or the clinical manifestations. So it's backing up, as we already described, into the right atria, but it's going to keep backing up. It's going in the wrong direction. It's backing up into the inferior and superior vena cava. And this is going to cause it to build up superiorly, to continue to move in the wrong direction. And what happens if pressure increases too much within our venous system? Well, the walls of the veins are not meant to withstand a lot of pressure. And so what will happen is, if enough pressure, because of that increase in volume, is found within our veins, it's going to start spilling out, causing what's referred to as peripheral edema. And we'll talk about the different types of edema coming up. But this is edema that is, and I should say fluid that spills out of the veins because there's just too much volume within it, creating too much pressure, so it pushes it out of the veins. We call that an increase in hydrostatic pressure, so the pressure of the volume of blood within the veins, pushing it out of the wall of the veins and into the tissues. And the fluid just sits there and causes edema or swelling. So So still on right heart failure and repeating a lot of what I've already discussed, we looked at this part right here on an earlier slide where I said that if somebody has scar tissue buildup, maybe they have COPD, we can't get blood properly past the obstruction, which might be scar tissue or tissue that's affected by COPD. And so the person, we're not able to oxygenate the blood properly. And that's the term hypoxemia, which is low oxygen in the blood. And that will come up again in our respiratory disorders lecture. I talked about the concept of diverting blood now to areas of healthy tissue, and this is done through pulmonary artery vasoconstriction. If we constrict the pulmonary arteries, it's going to cause it to back up, as already discussed, which increases pressure within the pulmonary arteries. So now we have an increase in pulmonary artery pressure, which is really pulmonary hypertension. So let's erase the slide here. So we're going to look at, once we get to the point of pulmonary hypertension that's created in this example by COPD or scar tissue formation, here is your pulmonary hypertension or an increase in pulmonary artery pressure. This is when we need to correct the problem. We need to reverse and correct the problem here. And as I spoke about earlier, if we can correct the primary problem here, then we can reverse to some extent that pulmonary hypertension and healing can begin. But if this doesn't occur, if we don't correct the primary or underlying disease, then we're going to start to see changes occurring now within the pulmonary arteries that could be irreversible. Scar tissue, hypertrophy, changes within the pulmonary arteries just so that they can withstand the pulmonary hypertension. But here's the problem. If we start scarring and thickening the pulmonary arteries, we are going to further increase the pressure within them because they're not able to dilate properly because they've been hardened effectively. And so this is where can lead to, that is the chronic pulmonary hypertension, chronic high blood pressure within the pulmonary arteries. It can lead to what's called cor pulmonale. And I told you earlier that cor pulmonale and right heart failure are sometimes used interchangeably. But the term cor refers to heart. Pulmonale refers to the lungs. And so this is where the term cor pulmonale, we can say, means heart disease caused by lung disease. In other words, the lung disease being, let's say, COPD or some scarring or whatever the case may be, over time eventually causes heart disease. And that heart disease, more specifically, is called right heart failure. One of the things that would be evident at this point within the heart is that it starts to hypertrophy and dilate. So let's look at this normal heart. We're going to look specifically at the right ventricle. You can see hypertrophy. Remembering that hypertrophy is an increase in cell size. Why would we have an increase in cell size? Well, remember that this right ventricle was trying to pump blood into the pulmonary circulation, but there was resistance, increase in afterload. So the right heart says, well, I got to contract harder. And eventually it adapts and gets bigger. And it gets bigger because if something's bigger, it can, in theory, contract harder. But anytime the heart hypertrophies, it is always pathological. Eventually, though, that heart muscle is not going to be able to get the blood supply that it needs to be as large as it is. And these cells will start to become injured. And when they become injured, and we'll talk about dilation of the heart in the other heart disorders lecture, but it just starts to kind of give way and it widens. So the heart muscle itself starts to thin and the chamber itself widens. And the blood will just continue to fill that chamber because we can't get it out, but it keeps filling. Going back to what I spoke about earlier. Now let's look at some of the complications of right heart failure before we move into left heart failure. I mentioned earlier, let me just go back to that slide for a moment, peripheral edema because of an increase in pressure within the venous system because we back up blood into it and then it spills out, causes peripheral edema. So let's see the different types of peripheral edema that exist. The first type of edema or complication is called jugular venous distension. Let's look at this slide one more time. I mentioned that if this right ventricle can't pump blood into the pulmonary circulation, what it will end up doing over time is backing up. And when it backs up, one of the things that can be seen is a backup into the superior vena cava here. And it can back up into an extension of the superior vena cava called the jugular vein. And it backs up into it and causes it to distend. So let's look at that here. It causes the jugular veins to distend, and we can see that here. And the reason it distends the way it does is because the jugular vein, like other veins, is not meant to hold a large amount of blood. Too much volume of blood increases pressure and causes the walls of the veins to sort of collapse and widen. So you can see jugular venous distension here. So jugular venous distension on an individual, along with other clinical manifestations, could indicate right heart failure. I talked about the general term edema already, which is where fluid from the blood is just pooling out into the tissues. Remembering that blood is made up of a large amount of water. And it's really the water within our blood vessels that leaves the blood vessels and pools within our tissues. Dependent edema. This is a type of edema that occurs in the feet and the legs when you're standing, and the sacral region, so think of like the buttock area when you're lying down. And that's because of areas that are predisposed to pooling of blood due to gravity. So somebody with right heart failure then are more likely to have swelling in their feet and their legs, but if they're bedridden, they might have significant swelling within their sacral region and their buttock. Ascites, this is a term that will come up in the digestive disorders lecture, but this is accumulation of fluid within the peritoneal cavity. So that's within the abdomen. So fluid that builds up in the abdomen is referred to as ascites. It can actually give somebody a pregnant belly appearance, whether they're male or female. Pitting edema. Pitting edema occurs when there's swelling. This is typical in the legs and the feet. There is edema, so fluid, water that has been pushed out of the blood vessels and is sitting within the tissues. And if you apply pressure to it with your finger, it will leave a pit when you remove your finger. And that's an indication when you see pitting edema that there's not just swelling, but that there's fluid that's trapped within the tissue. So all of these states above, in particular, these guys here, all involve fluid leaving the vessels and getting stuck within the tissues. And if this fluid gets stuck within the tissues, then there's going to be less returned to the heart in order to then eventually put it back out into the systemic circulation. even fluid that's trapped within the jugular vein. If it's trapped with, not trapped, but if fluid is within the jugular vein, too much is here because of that resistance I described earlier, then we can't properly move blood against the resistance. So remember, the jugular vein is going to be draining blood from the head, and it's trying to drain the blood, but we have this movement in the wrong direction. And so ultimately, we're returning less blood to the heart, to that right side, which means there'll be less available for putting into our systemic circulation. Now moving on to left heart failure. This is our busiest of slides. The rest are not too bad at all. So just really try to focus as I go through the details here and tell you what you need to know. Remembering back to the start of the lecture that the most common cause of left heart failure is ischemia to the heart, meaning that the heart muscle on the left side, that left ventricle, which we know is a larger muscle in order to be able to pump blood into our systemic circulation and perfuse our tissues. For some reason, there is ischemia to the heart muscle. It's not receiving enough blood to properly function. And if it doesn't receive itself, remembering that it gets its own blood supply off those little coronary arteries that come off right here that supply the heart muscle itself. And if for some reason it's not getting enough blood supply to the heart muscle, then it doesn't have enough oxygen and nutrients for its own metabolic processes that allow it to produce and use energy to contract, then it can fail. And so what we see with, let's say, that ischemia is that there's going to be a reduction in cardiac output. Why? Because the heart muscle, again, is not getting the blood supply it needs to properly contract to pump blood out. So we pump out less blood per minute than is considered normal. If we pump out less blood than is considered normal per minute, it means that we're putting less volume of blood into the systemic circulation. If we put less volume of blood into the systemic circulation, you should know that that means that there's also going to be a reduction in blood pressure because of that direct association between blood volume and blood pressure. So if we put out less blood, we know that we have those baroreceptors present as part of the aortic arch here and off the coronary artery, the carotid arteries not shown here. They're going to pick up the pressure, send it back to the vasomotor and cardiac centers that are found within the medulla, who will determine, okay, there's not enough pressure within the arteries, so we need to change that. And so what we will see in particular is this sympathetic nervous system response, as already discussed in this lecture, that leads to vasoconstriction. And one of the chemicals that contribute to that, or group of chemicals, are called catecholamines. You might recall that catecholamines, epinephrine and norepinephrine, are involved in our sympathetic nervous system, and they have the effect of causing vasoconstriction. Now, this vasoconstriction that we see, we're going to see vasoconstriction of certain blood vessels, including the blood vessels that you would have in your extremities, like your less vital areas of the body. This vasoconstriction means that the heart has to work harder to pump blood out of the heart. If the heart has to work harder to pump blood out of it, because think about downstream, now we have all of these. Think about a river that all of a sudden narrows. It's going to cause the water in the wider part of the river to back up, because it can't all get through that narrowed area. So that's going to increase our afterload, so that the resistance that left ventricle has to overcome to push blood throughout the body. An increase in afterload, rather vasoconstriction is going to cause an increase in blood pressure because we've always associated those two together. Remember that we're also going to see a response sent back because of the feedback from the baroreceptors to cause the heart rate to increase as part of our sympathetic nervous system response. These three variables occurring all of the time because of the left heart failing eventually are going to be too much for the heart. The heart will start to change. You'll see hypertrophy, as we've discussed in the past, so we have these very large cells. And even though you can see the enlargement here and the comparison between these cells and these cells, eventually it's not going to be able to remain in this state. And this is where, just like we saw with the right side of the heart, the muscle cells will become injured, they will thin out, and we'll see an enlarged chamber. And that's what we refer to as dilation. And the heart will not be able to effectively pump out blood into the systemic circulation to perfuse the tissues. Now, there is one more variable to discuss here, and that has to do with the kidneys. If this left heart side of the heart is struggling to pump blood into the systemic circulation, it's also going to struggle to properly perfuse the kidney. And you might remember the kidneys as being involved in helping to regulate our blood volume and our blood pressure. And so when we get less blood reaching the kidneys say, okay, something's going on. There's not enough blood volume here. The blood pressure is not enough. We need to try and make a change. But they, of course, don't know what the problem is. They're just going to try to help to fix it. But that will be unsuccessful overall. So what the kidneys will do is activate what you might recall as the RAAS pathway, the renin-angiotensin-aldosterone system. And you don't need to know about all these different steps here, but what I want you to be aware of are two main hormones, starting with aldosterone. Aldosterone, I want you to make note of what it does, thinking back to normal anatomy. Aldosterone is going to encourage our kidneys to hold on to more sodium instead of getting rid of it in the urine. If we hold on to more sodium in our blood, it means that water's going to want to follow. So we add more water to our blood, which means we're increasing our blood volume and increasing our pressure, which is really what our kidneys are trying to do. The other hormone that's involved here is, and so there's the sodium and water retention, holding on to more sodium, and because of osmosis, we're also holding on to more water, thanks to aldosterone. The other hormone is arginine vasopressin, which is the same thing as ADH, antidiuretic hormone. And what that hormone is going to do is stimulate the kidneys to get rid of less water and hold on to more water in our blood vessels. So very similar to aldosterone, except sodium is not directly involved. And so what we end up seeing in both the cases of aldosterone and ADH, or arginine vasopressin, is more water volume remaining within our blood, which means we get rid of less in our urine. The more in our blood means an increase in pressure, which was the kidney's goal. It identified a reduction in pressure, so it's going to work to increase it by adding more volume. So what we've done here is the kidneys have caused us to add more fluid to our vessels, and more fluid added to our vessels means that more is going to return to the heart, putting more stress eventually on that left ventricle that isn't able to pump the blood that was in it to begin with, let alone if we're adding even more to it, all leading to the same effects as described a moment ago. The final thing to mention on this image here is the effect that what's occurring at the level of the kidneys has on vasoconstriction. So that ADH, I had spoken about it with respect to adding more water to our vessels and increasing pressure, but ADH also has the effect of vasoconstriction, so similar to what we saw with our sympathetic nervous system. And then endothelin, will be released in these circumstances, and these are just peptides that have receptors and effects in blood vessels that cause a raise in blood pressure by vasoconstricting. And then the term cytokines, which I'm sure you've heard of before, these are also released. Cytokines are really just cell signaling molecules that are involved in inflammatory and traumatic responses within our body, but chronically being exposed to cytokines is going to further cause damage to the heart. So I know that was a lot of information, and we're going to now take some of this and apply it to this flow chart. So there's not a whole lot that's really new on this side. And my suggestion to you is to continue to listen to the lecture until you can grasp the concept rather than just memorizing it. Save some of your brain power. Okay. When I spoke about left heart failure on this image, I had spoken to it based on our most common cause, which is ischemic heart disease. Just going to correct that. But there are other causes of left heart failure, and one of the other causes is hypertension. So somebody that has high blood pressure can be predisposed to left heart failure. Why is that? Well, I want you to think about what I introduced earlier today and spoke about it in the atherosclerosis lecture, is let's say, it's not really shown well in this image, but I want you to picture the arteries within a person, and they're filled with these atherosclerotic plaques. And those arteries are now hardened and they're narrowed. This left ventricle, its goal is to push blood through the systemic circulation through all of the arteries. But if we have all of these arteries that are now hardened and they don't expand properly and the lumen size is reduced, then that left ventricle is going to have to work that much harder to push it through those narrowed vessels, narrowed and hardened vessels. And so that's why hypertension caused by atherosclerosis means that that left ventricle is going to be overworked. It's going to have an increase in afterload, the resistance that that left ventricle must overcome to push blood throughout all of the systemic circulation. So going to this flow chart here, we're starting with increased peripheral vascular resistance. And you can just put in brackets here, let's say atherosclerosis causing high blood pressure. Atherosclerosis will increase peripheral vascular resistance, meaning that these narrowed arteries that are hardened because of the atherosclerosis are going to create more resistance of the blood moving through the vessel, meaning that because it's been narrowed compared to, say, this, the blood moving through it has more resistance against the periphery or the walls. I mentioned that this means that we're going to have an increase in afterload. The left ventricle has to work so much harder just to eject the normal amount of blood. And because it is working harder, changes are going to be evident. And this is very similar to what I already spoke about over here. We're going to see neurohumoral changes. This just means some neurologic changes involving the central nervous system, or I should say the sympathetic nervous system, and the humoral changes refers to just changes of the components that are found within our blood. So don't worry too much about the details here. But what you do need to be aware of is what we already spoke about, that we're going to see the sympathetic nervous system activated. We're going to see that leading to vasoconstriction. We're going to see the renin-angiotensin-aldosterone system activated as well. And activating that renin-angiotensin-aldosterone system is going to lead to the effects of aldosterone, which is sodium and water retention. So adding more water to our blood vessels will increase our blood volume and blood pressure. And then we'll see arginine vasopressin, also known as ADH, released, which will stimulate the kidneys to retain more water. And again, more water, more volume in our blood vessels, increase pressure. Remember that ADH is produced by the hypothalamus and stored in the posterior pituitary gland, and then it will travel, that's within the brain, and then it will travel from there to the kidneys to have its effect. But this constant strain on the heart will lead to hypertrophy. You can see the hypertrophy again here. And a harder working heart means that the myocytes that make up the muscles are going to need more oxygen while they're working harder. Remodeling will eventually be evident, and then the heart won't be able to contract properly, which means we have this reduction in cardiac output, reduction in systemic blood pressure, and underperfusion of vital tissues for survival. So I know that was a lot of information on that slide, but the last little bit won't be too heavy. We're going to look now at how left heart failure can cause right heart failure, and I introduced that idea at the start of today's lecture. So really everything that I'm saying right now is review, but we're putting some of the concepts together. So let's say somebody has hypertension. And on this slide here, I mentioned hypertension caused by atherosclerosis as one of the causes, although ischemic heart disease was the most common, of left heart failure. So somebody has hypertension. That left ventricle has to work very hard to push blood through the systemic circulation compared to normal because the person has blood vessels that have atherosclerotic plaques and have become hardened. And so the left ventricle says, okay, what do I do to try to achieve the same result in perfusing tissues? I'm going to have to contract harder. So it increases its force. And we know that this is going to mean that it's going to need more oxygen, but it's not going to be getting more oxygen. And so that left ventricle becomes, the muscle tissue becomes hypoxic. And if it's hypoxic, then it can't contract properly, let alone harder. And so if it can't push all that blood out that it's supposed to, then the blood's going to start to back up. And when the blood backs up, it overloads the left ventricle. There's too much in it, and it starts to dilate, as mentioned before. And this is really more appropriately described, this increase in volume that's within here, as an increase in blood hydrostatic pressure. Hydrostatic pressure, speaking very basically, is just a pressure that's exerted from a fluid. In this case, the fluid is blood, and the pressure is being exerted against the walls of the blood vessels, or in this case, the ventricle. So an increase in blood hydrostatic pressure, in this case, just means that because the left ventricle can't push all the blood out, it starts to back up, but we still are adding blood to it, and eventually it becomes weak and it dilates because there's so much pressure exerted from the blood within it. We can't overcome it. And so these people are in a state of chronic left heart failure. Now, I'd mentioned at the start of today's lecture that left heart failure can lead to pulmonary edema. And this is very important for you to understand why. This left heart has failed. We already know that. It's dilated. What's going to happen now that it really can't pump a whole lot of blood out, but blood is still being added, is eventually it just starts to back up. And where is it backing up into? It's going in the wrong direction. Now it's backing up into the lungs. And it increases the pressure within the vessels so much that, just like what we spoke about with peripheral edema, the volume within the vessels spills out into the lung tissue, causing pulmonary edema, which is fluid within lung tissue where it's not supposed to be. So what this has created is an increase in pulmonary vascular resistance. We've backed up the blood into these vessels here, and some of it is spilled out. And Now the right side of the heart that normally pumps blood here to be oxygenated is now experiencing a bit of a roadblock because there's now this opposing pressure that's normally not there. Normally it should be a nice easy movement from deoxygenated to oxygenated blood and back to the heart, but now we have this opposing movement, this increase in vascular resistance. And so what does the right heart say? Well, in order to get past this resistance and get to where I need this blood to go, I'm going to have to work harder. And so the right side of the heart now has to contract harder to achieve the same thing. But it's having a difficult time. It can't get past this. So the blood starts backing up into the right ventricle because it can't move in a forward direction. And so we get this increase in preload within that right ventricle. Eventually, we're going to get this increase in preload within the right atria. It's going to back up into the superior and inferior vena cava, leading to all of that peripheral edema that we spoke about earlier. So everything that I spoke about with right heart failure now, you could put into this flow chart in order to help you understand the relationship between the two. When the left heart fails, it can eventually lead to failure of the right side of the heart. There are 3 factors that can lead to the progression of left heart failure, really contributing to what we call this vicious cycle of left heart failure. That is renal failure, a heart attack, myocardial infarction, and hypertension. So please be aware of these 3 factors that can lead to the progression of left heart failure. I'm not going to read all this out because I've talked about it quite a few times already, but what you can see shown here are the factors we've already talked about that can influence failure of the heart. So let's say this is already occurring in somebody with left heart failure. If they have a heart attack, it's going to further reduce contractility. If they have hypertension, it's going to cause a further increase in afterload, thinking back to how I described that earlier. If they have renal failure and their kidneys cannot get rid of enough fluid, then it's going to remain within our blood vessels. And the more fluid within our blood vessels means the more fluid is going to return to the heart, increasing preload. So when we decrease contractility, increase preload, and increase afterload in somebody who is already experiencing left heart failure, we are further worsening the situation. There's not really a whole lot new on this slide. It is a nice summary of the differences between right and heart failure with just a couple small additions. We already know with right heart failure that if the right heart fails to pump blood into the pulmonary circulation, that it can back up and cause peripheral edema. And we call this really congestion of peripheral tissues. There's just too much fluid, it's congesting it. And we talked about dependent edema and ascites. But we can also have this blood build up and spill out and congest the gastrointestinal tract. It can make somebody lose weight and not feel like they want to eat because of that congestion. And it can also congest the liver. So it backs up into the liver. Remember, venous blood should be moving towards the heart. It backs up into the liver, and the liver can't function properly. And so it can produce these signs and symptoms related to impairment of liver function. Now, if the left heart fails, we know that this is going to cause a decrease in cardiac output. So the left side of the heart can't put out as much blood. We also know that one of the side effects of left heart failure is pulmonary congestion. Remember, I told you that if it can't pump out this way, eventually it backs up and causes congestion. And we know that that can also progress to right heart failure, as already mentioned. Now, if you have a decrease in cardiac output, these patients receiving less blood to their tissues are going to show signs where their tissues are not functioning properly. They can't do simple activities. Pulmonary congestion, when it backs up into the pulmonary system and spills out into the lung tissues, called pulmonary edema. This means that we're not going to properly permit gas exchange. If we can't properly exchange carbon dioxide for oxygen, then it can cause balloonness of the skin, called cyanosis, and other signs of hypoxia, low levels of oxygen being received by our cells. Pulmonary edema, when we have all this fluid that builds up in the lung tissue that shouldn't be there, it can cause people to actually cough up a frothy sputum. So you're getting really fluid into your airways that isn't supposed to be there. Pulmonary edema can also lead to orthopnea, which is shortness of breath, which we know is called dyspnea. I'm sure you've heard of that term before. We'll talk more about it in the respiratory disorders lecture. And so this is shortness of breath or dyspnea that occurs when you're lying flat. And so people with left heart failure that have this pulmonary congestion or this pulmonary edema, they would be inclined to sleep sort of propped up in their bed or sitting up in a chair, because when they lie down, the congestion increases and that causes shortness of breath. And the final term on here is called paroxysmal nocturnal dyspnea. If we break up these terms, it helps to know what it is. Dyspnea being shortness of breath. Nocturnal refers to nighttime. And paroxysmal you can think of as being a sudden attack. And so what we have is this sudden attack of shortness of breath and coughing that occurs at night. So a sudden attack of shortness of breath and usually coughing that occurs at night, and it's quite severe. The final thing I wanted to mention, in case you were wondering the difference between the term congestion and the term edema, which I've sort of used a bit interchangeably, congestion will occur really first, and then spilling out into the tissues would be the edema component of it. Okay, so that is the end of today's lecture. Bear in mind the cardiovascular disorders component of this course is probably the longest and heaviest overall. Thanks so much for your time. Bye for now.